Welcome to Behind the Screen. I'm your host, Dee Mason. Now, last episode I met with BreastScreen Victoria's CEO, Rita Butera, Clinical Director, Dr. David Speakman, and Sue Viney from the Consumer Advisory Group. We talked about why breast cancer screening is so important, why early detection is key in working towards the ultimate vision of no deaths from breast cancer in Victoria. In this episode, we walk through the breast screening assessment journey from start to finish, from making that initial appointment to having a mammogram, to being called back for further tests as required, and for a small number of women being referred on for further treatment. Today I'm joined by three guests who each represent a critical part of that journey. Catherine Langford is Director of Quality and Clinical Care at BreastScreen Victoria. She helps us understand how assessment services are structured and what women can expect at each stage, including how results are communicated and how care is coordinated. Breast Surgeon and Clinical Director at BreastScreen Victoria, Dr. David Speakman, is back and explains the clinical side of assessment, why and when callbacks happen, what additional tests are involved, and how decisions are made when something needs further investigation. And perhaps most importantly, we hear directly from Liz Naval, who shares her lived experience of moving through that very assessment process. Together, I hope these three voices will help to demystify the assessment process, to explain why it exists and show how BreastScreen Victoria works to support women from the moment they book an appointment right through to whatever comes next. This is Behind the Screen, Episode 2, The Assessment Journey. Dr. Speakman, Catherine Langford, Liz Naval, thanks so much for your time today and welcome to Behind the Screen. Now, the focus of this episode is absolutely to walk through the stages of the clinical assessment journey, and I'm delighted to have you both, David and Catherine, here to help with that very thing. But I would like to start the episode with the story of Liz's experience with breast screening, because in some ways it's a textbook. It illustrates why frequent screening is so important and why early detection of breast cancer is really critical. But in other ways, it really highlights to me, and I hope to the listeners, how every woman's journey is just so different. Now, Liz, before I bring you in to tell your own story, I'd like to just give Catherine and David and our listeners a bit of your background for context. So Liz migrated to Australia 22 years ago. She was 35 years old, had a young son and a husband who's a doctor. She's a well-educated professional woman from a medical family in the Philippines with excellent English language and good health literacy. But still, the Australian health system was unfamiliar territory, and Liz and her husband were cautious about cost, eligibility, how the public system worked. So when Liz discovered a lump in her right breast, just at the age of 35, she returned home to the Philippines for treatment, to be closer to her mum and her sister, and also to a system that they knew. The lump was removed and it was found benign. So back in Australia, life went on. Liz remained healthy, active, no family history and no known risk factors for breast cancer. She'd never even heard of breast screening until she turned 50, when she received her first BreastScreen Victoria invitation letter. Liz assumes it's a mandatory test because she was raised in a culture where if the government tells you to do something, you do it. So she booked straight away, had her first mammogram and immediately received the all clear. 2 years later, same thing. Received another letter, screened immediately, and again the result was clear. So with 2 clear mammograms behind her, Liz says at this point, breast screening just becomes part of her regular health management because A, the government says you have to do it and they pay for it, and B, she's no reason to worry because it doesn't hurt, it takes 10 minutes, and the result is always good. Then came the third letter, and at this point, some women choose not to book because they've got the confidence of 2 clear screens, right? But Liz booked it. She went along for what she expected would be another routine mammogram. But this time, BreastScreen Victoria saw something they needed to look at more closely. And this is where Liz's assessment journey really begins. Liz, I want to bring you in and get you to tell the story in your own words from here. How did you feel when you received that third invitation for BreastScreen Victoria to come in for your routine mammogram?
You know, it's just the annoyance of thinking that, I will go to this process again. But I have to do it. So I said, okay, I'll just do it. I didn't make it a priority. But, I said it's free and, why not? I scheduled it and I had it done. But this time, I had that quick comeback. Yeah.
So they've contacted you and said, actually, there's something in that scan we're not totally happy with. Can you come back? Did they ask you to bring a support person or just to come back?
You can bring a support person. They called me also and they texted me. And also a letter.
Okay, so they were really keen to get you back.
Yeah, so that really prompted me. I need to go because when they called, that's when this might be serious.
Yes, so, I think, but they were persistent, and that got you to come back and make the appointment.
Yes, I made the appointment, and then they gave me the tests. I think it's another mammogram, and also ultrasound, and then biopsy.
All on the same day?
Yes.
Okay.
Yeah. So.
And how are you feeling at this point?
Because I have friends who always tell me that it's just a precaution, like extra care for you.
You go home after that, and then when's the next time you're contacted by BreastScreen Victoria?
So I think it's about a week. I received a text, asked me to come for the results. That's when you get the jitters. I had all the, other tests, 3D mammogram and biopsy. Yeah.
So they said come back. They didn't say these are your results on the phone. They said, why don't you come back in? Did they ask you to bring somebody with you on that occasion?
Yes.
And did you?
Yes, I did.
Okay. How did that assessment go?
We did not wait for long. The doctor called us, the oncologist, and then that's when the news was given to me.
Right. So it's you, your friend, and the oncologist in a room together?
Yes, yes.
Okay.
Yeah.
It was a woman, wasn't it? Your oncologist?
Yes.
So how did she approach that?
It's just a matter of fact that I need to tell you this. This is this is what you have, and this is, what we're going to do about it. But I did not hear anything anymore when it was told to me. I just heard that you had, You've
got breast cancer and then your ears went blah, 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 blah.
Yes,
blah.
Yeah.
I hear this a
lot. And my friend said, all I heard was, this is 98.9% curable.
Right.
So that's
you didn't hear that bit. Your friend had to tell you that.
I did not. So, and because I was already shaking and I don't know, there's so many things that will play in your mind. All those things that you don't really can process in one hit. It's just like you're floating and you're high and you don't know what's happening after that. But I remember my friend just holding my hand and he said, this is almost 100% curable. So that's what you just have to think about. Trust.
And the other great thing, Liz, about that appointment for you, I'm sure you don't think of many things that are great about that day, but you've got a history of 2 successful screens with BreastScreen Victoria. You've got the all clear twice. So I guess in your mind you must at least have thought, well, it can't have progressed more than 2 years because this has been. So that's the peace of mind that you get from being regularly screened, right?
Yeah.
Okay, so we've moved into treatment phase now. The oncologist, I assume, has made some recommendations.
Yes.
What did we get in terms of treatment? What path did we go down?
After that, I was introduced to a nurse. She brought me to a room. She was really, really very nice. I can't remember her name, but I remember she was very reassuring. And I just felt like this is what you just need during those times when, it's like hope that they give you. And I was already thinking about really fast forward, like maybe I will have a chemo. I need a wig.
Your mind was racing. After you've met with the nurse and she's explained the process, what was the first bit of surgery that we went in for?
They recommended for me to get lumpectomy.
And we're talking about your left breast, aren't you? Which is not related to the benign tumour you had on your right breast before, years and years earlier.
No.
Okay. So you've gone in, you made an appointment to go for a lumpectomy.
So I had a lumpectomy and then it was really, really great experience as well. And then I thought it was over. And then after 2 weeks, they came back to me and I was told that there is still like positive margin or they're not happy with the margin that was taken off. So I had to go back for another one.
So the first one didn't get all the margin. So we had to go back and have some more taken out of that same breast.
Yes. So they recommended, again, another lumpectomy. They want to be sure that the margin that they took was good enough. So again, I went to the hospital half day after. And by the way, I also had that, what do you call that? They injected me with something.
Oh, the contrast.
Yes, the contrast.
You can say it, David.
Sentinel. Well, it's called a sentinel lymph node biopsy.
Yes.
Oh, so they checked the lymph nodes as well.
Yeah.
Okay.
So before I had the surgery, they put a contrast or
Yep.
injected the contrast. Then I had again another lumpectomy.
Great. And that's
Yes.
that's the end of it?
No.
Oh, oh Liz.
Another one. So they sent me again another letter. Now they're asking me that they can do another lumpectomy or mastectomy. So they have given me the option. What would I prefer?
Yes.
Yeah.
And do you feel that you had the information you needed to make that decision?
The doctor was really nice to explain to me all the pros and cons and, radiations. But what was in my mind was I just want to have it taken off. That's it.
And to be clear, part of that decision-making process must have been, they said if you have another, if we take a little bit more from that same breast, you likely have to have radiation as well.
Yes.
But with a mastectomy of that left breast, there would be no need for radiation.
Yes.
You would just be thinking. And you opted
Yes.
to have the reconstruction at the same time?
Yes. Actually, I didn't even want the reconstruction at first. So I have to ask all my girlfriends.
That's what girlfriends are for.
Yeah. So the squad, I asked them, if you were in my position, what would you do? And they said, oh, of course, we would have the reconstruction because you're already there. Because part of the reconstruction would be a tummy tuck.
Yeah.
Where they So
the fact that tummy tuck is a selling feature for a mastectomy with a reconstruction is a terrible state of the world. And are you happy with the result, Liz? I mean, it's quite a journey you've been through.
I am happy with the result. It's just I don't want any more surgery, I hope.
Exactly. What's the future look for you in terms of your breast health? Does your screening protocol change to the rest of us?
I think so because I've already received a schedule for 2026 for ultrasound.
You're
and
obsessed with
yes,
you, Liz.
yeah. Yeah, I've got, I think, 2 tests
Okay.
to be done the same time when I was diagnosed. So that's already scheduled.
Are you worried about breast cancer now?
There will always still be worry, I suppose. But I think you just have to look, the positive thing and just live your life now.
Exactly. I think a
Yeah.
lot of people I've spoken to who have been part of the process come out with a whole different value for life.
Perspective, yes.
But it's also, you don't have the great unknown anymore. It's not like
Yes.
you don't know what's involved.
Yeah.
You do, and you can absolutely
Yeah.
kick it in the dick, as we like to say in Australia.
Yeah.
Yeah. Catherine Langford, I'd like to throw to you at this point. It's a lot following Liz, but can you just start with your thoughts on that whirlwind of a journey that our Liz has been on?
Thanks, Dee. Liz, I'm sorry to hear everything that you've been through. It sounds like it was a really long and extended process for you. And what's resonated with me is how many steps of the way that sometimes as health professionals, it's every day for us, yet for the woman who's going through that experience, it's super impactful from that text message or email or telephone call that you may get from us. That's your life. And as you said at one point, your mind is already way down the track, filling in what you think may happen. And sometimes, and hopefully that's, it's not always as bad as what our imaginations can fill in.
Well, I think, Catherine, it's clear from Liz's story and others that we've heard through this process that every woman's journey through breast cancer and even through the screening process is different. So in terms of developing a public health system, a model for population screening, how do we ensure that we're including all the different types of experience?
Look, it's really tough because public health, there's limited dollars, but we have a really strong program that has certain steps that need to happen along the way. We all have different support systems. Some people aren't blessed with a strong network of people around to support them. So we hopefully have a team of really caring, nurturing, kind and informed professionals around us to help step in and make sure that we're communicating in a really clear fashion, and so that the women who are coming through our service understand each step of the way what's going to happen next.
But sometimes, particularly migrant Australians, even if they're from an English-speaking background as Liz is, they might have just not the awareness. So their health literacy is not the same because they come from a country where it is either they fear the medical profession or they're not sure whether or not they're eligible for things. So I guess from a clinician point of view, how do we work around that?
Well, I think it's a really strong part of the health system in this day and age is making sure that we are catering to all of our differences. So whether it be our disabilities, our language, making sure that we have access to interpreters so that people can understand and be informed in their decision making. so that we can adapt our style of communication to ensure that the client or the woman is understanding the information that we're telling them and can participate in the decision making for the next steps if there are treatment options involved.
David Speakman, do you have initial thoughts on Liz's whirlwind journey through the system?
I think tragically it's a pretty common story. Not that perhaps all the surgery, but that when you said you heard the word cancer and you sort of switched off and went to La La Land, I think that is an absolutely common experience. And whilst we want to treat everyone respectfully to their individual needs, as Kath said, I think we're all humans, and if you start from that premise that you want to treat people and speak to them the way you'd like to be spoken to, or this type of stuff communicated, that's a good start. You want to try and put it in that person's context. And so often if it's a younger woman with young kids, not that this applies to everyone, but the first thing they will think about is, I won't be there for see my children grow up. And if you can put it into that context, and if they leave that consulting room only knowing that we, the medical profession, expect that they will see their children grow up and have grandchildren or whatever, then maybe that's all you'll get out of that consultation that day for that person. And if they left knowing that, that's a win, because the other thing Liz has said is there'll be multiple opportunities to ask questions and go through this and participate in what happens, when you got to the mastectomy part, and what is that the right thing for you or not, and reconstruction, all that type of stuff. I think the other thing I know we encourage our clinicians to do is be honest with patients.
Yes, which is to Liz's point, it seemed a matter of fact, but that is the fact of the matter.
Yep,
but
exactly.
What a brilliant masterstroke to send a nurse in straight away.
Often the nurse will be in when the doctor delivers this sort of news. And I think the nurse is critical, but more so because by the time, in most clinics, the nurse is sitting with the patient and the doctor's nicked off, that's when your brain's started to get a bit of a handle on it, and you actually started to process stuff and you're starting to ask questions. And so in that sense, the nursing staff are an incredible, wonderful resource for BreastScreen Victoria. As probably Liz would tell you, they're a key part of our program.
Catherine, we heard there from Liz that she never heard of BreastScreen Victoria before she turned 50 and got that now famous invitation letter. Tell us what it is and why it's important to the process.
The invitation, I think, is a unique part of living in Australia. There's no one likes turning 50. We certainly don't love getting that reminder that we're 50 from bowel screen and breast screen.
Yeah, what a happy birthday. I don't know why the government doesn't send us a nice big parcel. It says, poo on this, make an appointment to do that, and here's a nice bottle of something sweet for you. I don't know why.
I know, it'd be so much more fun.
Also, can we just talk about being 50 is such an extraordinary time. A woman at the age of 50 may have teenage children going through their VCE exams, a parent who's crook, entered menopause, past perimenopause, in the full swing, and then gets a note from the government saying, oh, by the way, can you come and have a look at this for us?
The sandwich generation,
yes,
as we often refer to. Liz was talking through those messages that she received that may not have acted upon so quickly. And in fact, I have to self-confess, I may be ignoring one text message I'm getting at the moment as well, and I'm in it. So it's not a comfortable experience, as you alluded to before. Traditionally, women care for others and not ourselves, but we're lucky in Australia to get that reminder from our government encouraging us to go and look after ourselves, and that is have a breast screen.
So, Catherine, are you happy to walk us through the journey from the letter right through?
So at the point of receiving your letter, you will then, great technology now, you can make your own appointment via the online system at a time and location that's convenient to you. You can also telephone our lovely contact centre and they'll help facilitate that for you. You then attend one of our screening clinics, and they're all throughout the state. Sometimes even a screening van will attend a location that we don't have a fixed site at, which has great attendance from local communities. And then you will be asked by the reception staff to verify your information. That's part of the consent process. And hopefully really small wait. We tend to run on time. It's one of the only appointment systems that certainly I'm involved in that runs on time. And you'll
hairdressers should take note of what BreastScreen Victoria is doing.
It's a marvellous system. There's a lot of information though that has to get conveyed during that time.
Even though it's a 10-minute appointment, you really must get there a little bit earlier to fill in your forms and confirm your information.
Yeah, that's extremely helpful. And we do try not to keep you, as we've just discussed, and you'll be swiftly taken in by one of our skilled radiographers. So we encourage women to wear something comfortable that you can easily take off.
And here's a pro tip: skirt and a top, or pants and a top, not a dress.
Correct. Yeah, really important. Or a shirt that you can just slip a shoulder off. But we certainly have gowns available for people that are not comfortable. It's important, again, we want women to come back. So we will do our absolute best to make sure that the environment suits you. It does run swiftly. It's an efficient process, but certainly one that we really do our best to make sure that you feel comfortable.
So really you're in, disrobed, 2 scans each breast, and then out. And then what happens? When do the images get looked at?
In Cyberland, those images are sent to a central location, and our skilled radiologists now will read that. So you will have 2 humans look at your images, and then you may have a third human look at that, depending on whether there's agreement between the first 2 humans. And that then triggers the next step in the journey, which is recall.
So what percentage of women would get the all clear on that?
94% of women who screen, and then approximately 6% or just below 6% will get recalled to clinic.
We just reach out via whatever method is available to contact that woman and say, can you come back for a further look?
That's right. It's done in a variety of ways, but often we try and have one of our nurses speak to you by telephone. A lot of people don't answer their phone these days, so red hot tip to the listeners: if you've had a screen, listen for that call that you don't want, but unfortunately 6% of you may get. Mm-hmm. So it's really important then that the nurse speaks to you. Some women will have, we get the variety of reactions in that, which is all normal, but we try and make sure that women understand that this doesn't mean that you have a cancer diagnosis. There's a whole range of things that can be seen on an image, but we need to have a closer look.
Okay, so what are the options? You come back for your call back.
So we usually get you back within 1 month of having that screening appointment. So when you come into clinic, we then go and do another mammogram. And that's confusing to some women, but it's actually a 3D mammogram. It does give us a very different set of images for the doctors to then go and have a closer look and help make some decisions from that point as to what happens next.
So I've got the call back. You've done your range of images, and then it goes off to be reviewed by whom?
So our radiologists in clinic will take a look at that. It's the beauty of working in a multidisciplinary clinic, because we have our surgeons working alongside our radiologists, and we don't want to be doing any interventions on women that don't need it. So really careful attention is given to the images that are taken, and then a decision's made as to whether further an ultrasound is needed. We try and get things done as quickly as possible, but it can be a long wait. So we do say wait for up to a few hours. Now, after that 3D mammogram, the majority of women are actually cleared at that point. So
the majority of that 6% goes home.
That's right.
Yep.
And, we're all obviously very happy for the woman that can go home. And
is there do you do like a big archway as they exit with everybody clapping? I've seen that on telly. Do you do that?
Oh, no, we don't. But we are mentally doing that, I guess. You can usually tell as the woman and a support person is walking with a smile on their face out the door, and you can hear the conversations and the relief. Yeah.
So they've gone home, but some people will require further testing.
That's right.
And you give them that news on the day.
It's, again, quite swift. You'll be taken into it to have that ultrasound in the clinic at that time.
I've had my 3D mammogram. The doctors have looked at it. Perhaps even a surgeon has looked at it. And then you say, okay, we're going to need some further tests, and we're going to go and have
an ultrasound. That's right. And then, so from that point, a further decision's made as to whether or not we need to have an even closer look, which will mean a biopsy.
And that could all happen on one day.
Absolutely.
Yep. The 2 bits of news that you could get after that are right to go?
Right to go. Absolutely.
That's when the parade happens.
Yeah, well, the right to go will be after the ultrasound, but unfortunately, if you have to have a biopsy, there's further information that needs to come, and that involves our pathology team. So pathology can take up to 1 week to get those results.
So if you've got a biopsy, you probably are going home. You're not really going to stay there for the full week. You'll go home and await more information.
Yeah, that's right. And we appreciate that can be a difficult wait as you're waiting for us to contact you. We try and make the appointment to return to to clinic for your results in advance so that women really understand that we need to have a conversation in a week's time, and hopefully it's an all clear conversation.
What level of care is there at this point? Who's with me apart from my support person? Is there people I can talk to? I have questions already.
Yes, again, back to that multidisciplinary team. So we have the radiographers who will talk to you every step of the way when they're with you. Same with our radiologists. Nursing team are a really strong part of that process. They are managing the patients throughout the, walk in this room, get changed to you. Where would you like to sit? So sitting around in a gown, many people don't want to sit in an open area with other people's support people. They might be there on their own and want a quiet place to sit and read a book. So you could sit in a gowned waiting room that is women only, or you can sit out in the courtyard. Our service, you can sit out in the sun. We will find you when we need you. So it's really about trying to make sure that you're comfortable when you're coming to have an assessment.
Okay, so all the assessment has happened, and then there must be a point at which Dr. David Speakman gets involved in this process.
There is. I've just wanted to shout out to because I think the people we didn't mention just then about who's there to help you are the admin staff. Mm-hmm. And a lot of the admin staff at BreastScreen have been there for years. They've seen all sorts of women come and go, and I think they're actually fantastic at either helping ladies who might just need simple things, but then escalating to the nursing staff or the clinicians if they see someone in the waiting room who's not looking right or looking worried, then they'll flag it up and that lady will get looked after.
The doctors have reviewed the thing. We've asked for further tests. The further test would be an ultrasound and then perhaps a biopsy. When does Dr. David Speakman or his ilk get involved?
So if you're going to have a biopsy, if everyone's looked at your 3D mammogram or tomogram they've taken on the day and an ultrasound in many cases, and the team's decided a biopsy is the right thing to offer this lady, then that's usually when the surgeon will go and examine that lady to make sure there are no lumps or bumps to feel, to go along as part of the assessment, but particularly because sometimes after a biopsy you can get bruised. We'd like to know what's going on before that happens. And so that's recorded for everyone to use down the track. Then usually the surgeon next appears after the biopsy's been done and we've got a result. So for women who do get a biopsy done, so that's a needle core biopsy, they'll come back and get a result, as Catherine was saying, a few days later, depending on how fast the pathology turnaround is. Luckily, a lot of those women will get a benign diagnosis, so that's not cancer. A number of those things we can safely leave alone, and a lot of women, when they had the biopsy, will have had a little clip put in, a little marking clip. So that's a 3mm titanium thing. That doesn't set off the alarm at the airport, which is very important. But it does let us know that area's been biopsied before, and so we can keep an eye at the next mammogram. So for some women, you'll come back after your biopsy result and the surgeon will say, all clear, no sign of cancer, this is a benign lump, you don't need to do anything else about it, and they might explain exactly what that is.
So a benign lump can't turn?
Generally, excellent point, because if it was a type of benign lump or a change that might turn, so that's another result you get on the biopsy that might lead to the surgeon saying, look, no cancer, but we do need to take this out because we're a little bit worried that it might turn or might be a problem for you in the future. But that doesn't mean going into the whole treatment pathway that Liz experienced. Usually that's just a simple, small operation, in and out in the same morning type thing.
You've got the, I would say, unenviable task if I didn't know you, but you've since told me that it's actually an honour and a pleasure for you. You're the guy that has to give these women the news. So tell us about that conversation.
It's interesting, as a surgeon, when you train, you want to learn how to do the operation and be fantastically wonderful, come in your fighter plane and whip something out and everyone's better. And I think, luckily, over the years, things have changed where giving someone news about a cancer diagnosis, for example, we try to teach it just like we teach how to remove a gallbladder or how to do a mastectomy or how to do anything else. There are right ways to do it that are less impactful on the woman you're talking to and that give them a better experience than perhaps we used to do it in the past.
So Giving Bad News 101 is a course at surgeon school?
Absolutely. Right. At medical school, really, now. Certainly at surgical school.
So what's the best way to deliver that kind of news?
So I think honest, clear and concise is what we're looking for. And that will, as we're talking about, you need a different approach for everyone because not all people take information the same way. And so often you might be a surgeon meeting that lady for the first time when you're about to give a cancer result. And so a lot of people will lead into that by saying, oh, can you just tell me what, I've got some notes here about what happened last time, but did you had a biopsy, is that right? And check which breast it was, just to get a bit of comfort and that allows you to get a bit of understanding about where their head is at. Because some ladies will know. So often when we talked about the surgeon doing the examination, if having looked at all the x-rays, so the mammograms, the ultrasound, and we've felt the need to do a biopsy, if we're pretty confident that lady's got a breast cancer, the surgeon might allude to that fact when they're doing the examination. It's often called a shot across the bows, so that the woman gets some idea about how seriously we think the problem is, and also that when they come back to this type of visit, when they're getting a result, maybe it's not such a massive shock. Mm. But I think that, to be honest, that sort of opening stuff is more about trying to get a rapport and an understanding of that particular patient and how she might like to get information.
What do we do if somebody's from an at-risk community or a non-English speaking background? Like, how do we work on the fly at BreastScreen Victoria to get the right level of support in?
That's where the role of the nurse is really important and can be quite powerful. Not only are you reinforcing the information that has been delivered by the surgeon, you're also using those assessment skills to see if there are any other services or steps that need to be taken to make sure that the woman's safe when they're leaving that appointment, and will also participate in the next steps that are needed.
BreastScreen Victoria invites women and trans and gender diverse people aged from 50 to 74 without breast symptoms to have a free 10-minute breast screen every 2 years. Breast screens with us are performed by a woman radiographer and don't require a doctor's referral. With over 50 clinics and 2 mobile screening services across the state, you can choose a clinic and a time that's convenient for you. Book at breastscreen.org.au or call 13 20 50. Dr. Speakman, we're going to talk a lot more about this particular subject in our innovation episode 5 of the series. But can you explain to me what breast density is, why it's become a bigger deal in this process, and whether or not we treat women with a higher breast density different in this process that we're talking about?
Breast density, firstly, is really, so you can't tell how dense your breasts are by feeling. It's just a rating given on a mammogram. It has nothing to do with how you feel. So it's really what your breast tissue looks like on a mammogram, and basically it's a ratio of the actual breast tissue, so the fibroglandular tissue we'd call it, so all the milk ducts and the lobules that make milk. So it's a ratio of that tissue to the fatty tissue that surrounds it. And the more fatty tissue there is, the lower your density will be, but also means that easier it is to spot problems on your mammogram. And so that's why lately, BreastScreen Australia has promoted that all BreastScreen units now try and report breast density on the letter you get. So even if the letter back from BreastScreen says the patient is all clear, it'll also have that patient's breast density on it. Breast density is one risk factor for both getting breast cancer, but also for making it harder to find on the mammogram.
See, now that's the bit that I think wasn't clear to me until I started to look into it, and I wonder if it's not clear to other women. So I thought that the issue of breast density was it's hiding cancers behind it. Like, it's hard to see the cancer because of the dense tissue.
That's definitely an issue.
But you're now saying that it increases your likelihood of developing a breast cancer as well.
That's correct. It's probably
not just not diagnosing, but developing.
Both.
Okay.
If you try to divide that up, the not seeing it is a bigger part of it, but there is an inherent higher chance of getting a breast cancer in women who have high density breasts because you've got more fibroglandular tissue. You can't control that really. The other thing to mention at this point is about breast density is that it can change with time. So it'd be pretty common for premenopausal women to have higher density breasts than women who are postmenopausal. And that's another reason why screening's better in 50 plus women than in women who are under 50. But we do have to be clear that it's only one of the risk factors for breast cancer. And what you'll hear in episode 5 is that there may be other ways to address that looking at a mammogram. And I think as breast screening goes forward, you'll still hear about breast density, but actually the way the mammogram's interpreted will be far greater than just breast density.
So, Catherine, if a woman's been through the process we've just discussed and has been just so unlucky enough to have been diagnosed with a cancer and requiring further treatment. That's the end of your relationship with them. What's the handover process like?
So we make sure that all the information that we've gathered as part of the assessment journey is wrapped up and put into a pack, available electronically, and we then share that to make sure that your next treating clinician has all the information needed to take care of you.
So I have questions for both of you, Catherine, and for Dr. David. What happens after a woman has had a cancer diagnosis and then had treatment, independent of BreastScreen Victoria, obviously? Do they come back to the program? When do we go back to regular screening?
It depends on what your diagnosis was. So for women with a cancer diagnosis, the BreastScreen program isn't right for you in the first 5 years after your diagnosis. So after that 5-year period, you are welcome to come back into the BreastScreen program.
In fact, you're encouraged.
You are.
Usually what will happen is your treating team will say to you, good news, you've gone 5 years without a problem, isn't that fantastic? And now it means you could go back to a more routine program like BreastScreen, whereas in that first 5 years, you'll get far more intensive follow-up and screening by your treating team.
Can I ask, because it's a question that will be in other people's heads, you've had a mastectomy followed by a reconstruction. Does that need screening in the future? Is there any breast tissue in there? I would think no.
The short answer to that question is no, because you're right. Or if we did the mastectomy right, 98, 99 or 100% of your breast tissue is gone, so there's nothing there for the mammogram to see.
Okay.
It is incredibly rare to get a recurrence in a flap or an implant after a mastectomy. Trying to do an image of it is usually not very useful.
Let's talk about Liz's case just as we wrap up. Is Liz more or less likely to be a risk for breast cancer because she's had breast cancer?
She's certainly at a slightly higher risk of getting it than any other woman who's walking down the street. But if you said someone who's had a mastectomy at age 50, over her lifetime, there's about a 3% chance she might get a problem in the other breast.
Liz has done literally nothing wrong. She's lived a good life. She's had her 2 scans and then another one. I think this just tells us that screening is...
It's not a secret. Screening saves lives, and Liz is an example of that, because despite the large surgery and the difficult journey she's gone through with several operations to get to that point, we would be fully expecting that she's going to live till she's 100 or some number like that. The great thing about screening is at the get-go, we'll tell 94% of you you're A-OK. That, as we've talked about 6% of women will get a callback, but 5 out of 6 of those women will get cleared as having no cancer. So really less than 1% of all women who have a mammogram, the screening mammogram, will be diagnosed with breast cancer. But those 1% then have a chance to live out a normal, happy, healthy life with their families, or doing whatever they wish to do, whether that's work, sail a boat, travel the world, whatever it might be. Their opportunity to do that is preserved. Whereas if you wait until you've got a lump, then your chance of that happening is pretty much halved. And I think that's an amazing stat about screening, that the outcomes are, if you like, 50% better, or that 50% of women who come with a palpable lump are going to have a lot of trouble as a result of their breast cancer, and some of those women won't survive. Whereas the opposite is true in screening. Yeah. We talked the other day that 95% plus of women who come from the screening program will live long, happy, healthy lives.
Yeah. Well, Dr. David, you do make a very compelling case for breast screening, as always. And your passion for it is not lost on myself, and I imagine not lost on our listeners. So thanks for that. And thank you all, everybody, for coming along. I just want to give the last word to you, Liz, if I could. Liz Naval, if you had the opportunity to speak to one woman to convince them of the importance of breast screening, what do you think you would say?
I would say it's only 10 minutes, but it will be the future 20 million minutes of your life. So you have to do it for peace of mind, and not just, for your family, for your loved ones, for your friends, but also for yourself.
A really big thanks to my guests today, to Dr. David Speakman, Clinical Director at BreastScreen Victoria, Catherine Langford, Director of Quality and Clinical Care at BreastScreen Victoria, and perhaps especially to Liz Naval, a member of BreastScreen Victoria's Consumer Network. Behind the Screen is available on podcast platforms and via breastscreen.org.au/podcasts from February 2026. Come and join the conversation on Instagram and Facebook. Make sure to like, follow and subscribe so you'll be notified weekly when the episodes drop. And if you know someone who's curious about breast screening or could really benefit from these conversations, please feel free to share. Thanks for listening, and tune in for the next episode of Behind the Screen. I'll be sitting down with Eliza Alford, Program Manager at Bendigo BreastScreen, Carmel Lacasso, a member of BreastScreen Victoria's Disability Consumer Advisory Group, and Kathy Eccles from BreastScreen Victoria's Consumer Network. That's next on Behind the Screen, Episode 3, Hard to Reach Communities.